Okay, everybody, welcome to week 11. We're going to be discussing lab biomarkers and assessment tools for pain. So we're going to review this paper. I thought it was a really good paper, and I can add it into the lecture for you, the full paper, but here's a couple excerpts from it. Assessment of patients with chronic pain. So although there have been many scientific advances in the understanding of the neurophysiology of pain, precisely assessing and diagnosing a patient's chronic pain problem is not straightforward or well defined. There is no one-to-one relationship between the amount or type of organic pathology and pain intensity, but instead, the chronic pain experience is shaped by a myriad of biomedical, psychosocial, so the patient's beliefs, expectations, their mood, and behavioral factors such as the context, responses by significant others, etc. So chronic pain alone is estimated to affect 30% of the adult population of the U.S., upwards of 100 million adults. And despite the soaring costs of treating people with chronic pain, relief for many remains elusive, and complete elimination of pain is rare. In the absence of identifiable organic pathology, the healthcare provider may assume that the report of symptoms stems from psychological factors, and they may request a psychological evaluation to detect the emotional factors underlying the patient's report. For example, the organic basis for some of the most common and recurring acute, such as headaches and chronic back pain, fibromyalgia, pain problems are largely unknown, while on the other hand, asymptomatic individuals may have structural abnormalities, such as herniated discs, that would explain pain if it were present. So it's always interesting. I know everyone here works in the clinic, but whenever you shoot x-rays and sometimes you see a totally degenerated spine and the patient has no complaints of pain, they may just be coming in for wellness care. Or if you see a spine that looks great and the patient has 10 out of 10 pain. So sometimes it's not the structure that is causing the pain, but it could be the plasticity or the negative plasticity in the pain pathway that's creating the perception of pain. So a comprehensive assessment is needed that addresses the biomedical, the psychosocial, the behavioral domains, as each contributes to chronic pain and related disability. So here in the paper they discuss the comprehensive assessment of the person with chronic pain. Turk and Meichenbaum suggested that 3 central questions should guide assessment of people who report pain. So what is the extent of the patient's disease or injury, their physical impairment? That's number 1. What is the magnitude of the illness? So what extent is the patient suffering? Are they disabled? Are they unable to enjoy usual activities? And then, does the individual's behavior seem appropriate to the disease or injury? Or is there any evidence of symptom amplification for any of a variety of psychological or social reasons? So they get the attention that they're seeking, if that's the issue. Mood-altering medications. Is there some sort of financial compensation? So again, pain it's a tough one to really try to determine everything. So this is just a couple of questions just to help kind of guide the clinical decision-making process. So healthcare providers must evaluate the whole person and not just the pain. I think sometimes when we get busy in the clinic, it's easy to just say, hey, this is the cause of your pain, and then try to fix it, and then the people come back and they say, hey, I'm not better, what's going on? So, taking a little bit of extra time to try to evaluate other areas that may be contributing to the pain could be a benefit for the patient's outcomes and for your time as well. So the general goals of the history and the medical evaluation are 1, to determine the necessity of additional diagnostic testing if that's necessary. We'll go over just a couple biomarkers that you can check to see if there's any elevations in those. Number 2, determine if medical data can explain the patient's symptoms, their severity, and then their limitations. Number 3, make a diagnosis. 4, evaluate the proper and appropriate treatments. Number 5, establish the objectives of the treatment. And then 6, determine the appropriate course for symptom management if a complete cure is not possible. Everyone knows this, just coming up with a treatment plan for the patient. based on what you find. So significant numbers of patients that report chronic pain demonstrate no physical pathology using plain radiographs, which is what I just mentioned, CAT scans, or electromyography. So again, pain subjective. So if patient's complaining of pain, it would be of benefit for us to really try to dig in deep and discover where the pain could be coming from. So this is a brief psychosocial screening tool. It's called ACT UP. So the A is activities. So how is your pain affecting your life? So you could talk about like some activities of daily living here: sleep, appetite, physical activities, relationships. Number 2, coping. How do you deal or cope with your pain? So what makes it better? What makes it worse? Think. Do you think your pain will ever get better? I think that's an important one because some patients that are in chronic pain, when they come into the clinic, you really have to try to change their mindset, their outlook. They've been in pain for so long that sometimes they think, yeah, this is just another treatment. But if you can try to set their brain up for success and have them focus on getting better, it could really help the patient get better in the long run. I've used that in my clinic, especially with chronic concussion patients and people suffering from really debilitating neurological disorders. We try to shift their focus and make them focus on healing and make them part of the team. Upset. Have you been feeling worried, anxious, depressed, down, or blue? That's a big one. We've talked about depression in the lectures before, but depression lives in the frontal lobes. When the frontal lobes aren't firing appropriately, whether they've been affected by some sort of pathological issue or if there's just decreased blood flow to the area, if you don't have strong frontal cortex output, you're going to have those feelings try to take over. So having a really good frontal lobe is important. And making sure that they're not chronically in an upset or down or blue mood. And then how do people respond when you have pain? Do they feel like they're getting the right attention that they need? Do they feel like people think that they're just chronic complainers? Again, that's just the outlook that the patient has. I think, again, that's important for their healing as well. So in addition, patients with chronic pain problems often consume a variety of medications. It's important to discuss a patient's current medications during the interview, as many medications are associated with side effects that may cause or mimic emotional distress. Healthcare providers should not only be familiar with the medications used for chronic pain, but also with side effects from these medications that result in things like fatigue, sleep difficulties, and mood changes to avoid a misdiagnosis of depression. One thing I think that's really important for us as providers is knowing what medications people are on, and then also, just like this paper says, the side effects. I think that sometimes this is something that's missed as well when we're doing alternative care, is really doing a thorough review and history of the patient's medications to make sure that you're not treating a side effect of a medication or their symptoms are not coming from a side effect of the medication. And then also, if you're going to be supplementing, making sure that none of your supplements that you're providing are going to interact with any of the medications that the patient is on. I think that's really important. So just something to note there. The use of a daily diary is believed to be more accurate as they are based on real time rather than recall. So this was discussing some of the tools, the psychosocial and psychological tools that you can use for pain, which I'll show you in a second. But having a patient write down a daily diary can be really good to get a thorough history of maybe what may exacerbate the pain, make it feel better. But then also, we use diaries for healing. I mentioned this before in the lectures, but Dr. David Hanscom, he's a spinal surgeon out of Seattle. He almost, I guess you can't say this, but he was able to help a ton of people by doing what I think is functional neurology for patients and having them diary their pain and write about their pain and doing different things like this to help the patient kind of take control of the pain, and patients would get better. They do better with post-surgical pain. They do better with pre-op stuff, and then some patients didn't even need surgery. So having a daily diary to understand the pain, get a good background on where the pain is coming from, what fixes it, but also it could be used as a healing tool. So David Hanscom's work is worth checking out. His website is backincontrol.com. I would recommend it for any patients that you have in the clinic with chronic pain. He's got a lot of free information on his website, and his book is great. So research has demonstrated the importance of assessing overall health-related quality of life in chronic pain patients in addition to function. So there's a number of well-established psychometrically supported HRQL measures. So the Medical Outcomes Study Short Form Health Survey, that SF36 that people use, I'm sure, in the clinic. General measures of physical functioning. So there's a pain disability index. And then disease-specific measures such as the Western Ontario McMaster Osteoarthritis Index, and then the RDQ to assess function and quality of life. There's also a ton of other ones too. Those are some good ones, and you can just find them online, print them out, and have your patients fill them out. Good to know, and then have pre-post objective data. The presence of emotional distress in people with chronic pain presents a challenge when assessing symptoms such as fatigue, reduced activity level, decreased libido, appetite change, sleep disturbance, weight gain or loss, and memory and concentration deficits, as these symptoms can be the result of pain, emotional distress, or treatment medications prescribed to control pain. So again, we're not psychologists, or psychiatrists, but it's important to really understand the patient's brain state, like knowing where they're at. Are they having emotional distress? Because as we've seen in the other lectures, if there is depression, if there is anxiety, it can either exacerbate the pain, and pain can settle in easier and quicker and create more plasticity in a negative fashion, or the pain being there for so long can create the depression or the anxiety. So which came first, the chicken or the egg? The jury, I think, is still out there, but it's important to be able to understand if that's a part of it, because it may change the course of treatment for the patient. So the Beck Depression Inventory and the profile of mood states, they're psychometrically sound for assessing symptoms of depressed mood, emotional distress, and mood disturbance. And they've been recommended to be used in all clinical trials for chronic pain. So we've talked about the Beck. I don't believe we've talked about the POMS, but I have the Beck in this lecture for you. The scores must be interpreted with caution. The criteria for levels of emotional stress may need to be modified to prevent false positives. Just like with anything, you have to do your due diligence, and you can't take everything at face value that you do in the clinic. So here's a sample of some standardized tools for chronic pain assessment. I think a lot of us use these right here. Some people use the facial pain scale. I don't use the pain thermometer too much. We used to use it in the hospital, but we mostly just use the verbal rating scale, or the NRS. So you have these unidimensional pain measures, pain quality and location. So you can use the MPQ or the SFMPQ2. You've got your PDI down here, so pain, interference, and function. And then when we get down, here's the SF36 here. And I like this. This comes straight out of the article, but it tells you a little bit about what's assessed in each of these tests. We're going to review the Beck Depression Inventory, so assessing for depressed mood. And you don't have to do all of these. We use 2 or 3 in the clinic, but just good information to have in case you wanted to pull them out and use them in the clinic. So here's the numeric pain scale. It's always funny because I work with some trainers, and they'll grade on different scales than I use. So I always use the 10 scale. So what's your pain? 10's the worst, 0's the best, and they'll give me a scale. But they use some of the people I work with, they'll use a scale out of 6. I just use a scale out of 10. So this is the numeric pain scale here, and then you may use the FACES scale if they have difficulty with numbers. So here's the FACES scale, the Wong-Baker FACES pain rating scale. Are you very happy, which most happy people aren't hurting, or are you very sad, which that's probably pain there. So you can use that one as well. You can use that for the kiddos if you have any kids in your clinic. And then here's the Beck's Depression Inventory. So it goes through, I believe, 20 questions. It's self-scored, but the scoring is at the end. So number 1, you go through 0 to 3 in each of these. So just have the patient fill it out. And I just opened up all of the questions there. And then, 21 questions. So you've completed the questionnaire, add up the score for each of the 21 questions by counting the number to the right of each question you marked. The highest possible total for the whole test would be 63 if you marked 3s for all 21. This would mean you circle number 3 on all 21 questions. Since the lowest possible score is 0, the lowest you can get is 0. That would mean that you're pretty good. And then it just goes through and tells you ups and downs are normals, because one thing you have to remind patients too is that, having good days and bad days isn't a bad thing. Sometimes you have some bad days, but if you're scoring above a 10 on here, then you may have a mild mood disturbance. I had a young 16-year-old guy come in, excellent football player, and his grades were slipping in school, and we just did, I practice functional neurology in the clinic, so we did a lot of frontal lobe exercises. But I just told him, I was like, hey, you're gonna have these days that you're just not feeling good, and that's not abnormal. If it gets to a point where you feel like you can't control it, then that is. But you just have to remind the patients that good days and bad days are gonna come, and just continue to be that positive shining light, because people who are in pain, people who aren't doing well in things that they used to be good at, it's easy for the brain to be lazy and say, well, that's my new normal, and then they become depressed and sad, and that's no good for anybody. So just my little soapbox there. Always be a positive shining light for your patients. They need everything that you can give them. So that's pretty much it for the assessment tools. We're just going to review a couple lab biomarkers for pain, and we're just going to go over a couple papers here. So I actually really like this paper, since we are all in the alternative field working a lot, I'm assuming, with low back pain, but this is inflammatory biomarkers for low back pain and disc degeneration. So it was a review article, and since inflammation contributes to the pathogenesis of low back pain, pro-inflammatory cytokines can serve as molecular biomarkers of pathological processes associated with disc degeneration, herniation, and low back pain. So growing literature suggests that the presence of these inflammatory mediators can be measured systemically in the blood of patients with low back pain. So that was the one thing, doing my own research on this. Inflammation causes pain, and so I would think that inflammatory markers would be elevated in patients with pain. Some studies showed that they were, some studies showed that they weren't. In the acute phase, you're going to see that there were some elevated inflammatory cytokines and interleukins. In the chronic phase, some were elevated, some were not. So it just depends on your scope of practice. If you want to run blood work on patients to see which biomarkers are elevated, which aren't, that's fine. Just make sure that you're practicing within scope. So acute and subacute for low back pain patients, high sensitivity C-reactive protein. So HSCRP was the first described acute phase protein and is a systemic marker of inflammation. So the HSCRP serum levels, they've been positively associated with pain levels in acute low back pain patients. So acute low back pain increased CRP. CRP should be a very low marker, so anything that's elevated should tell you that it's positive for an acute inflammatory response, systemic. Sturmer et al. Reported difference in mean HSCRP levels in acute low back pain by the pain category. Those in higher pain categories exhibited higher HSCRP levels. In addition to the HSCRP, tumor necrosis factor, so TNF alpha, soluble TNF receptor 1, so STNFR1, and then interleukin 6 have been identified as possible regulators of different aspects of acute low back pain. So TNF alpha and interleukin 6, they're both pro-inflammatory cytokines that have long been studied in mechanisms of disc degeneration and are also well-established mediators of nociception. Interleukin 6 helps mediate the acute phase response to injury by promoting monocyte differentiation into macrophages and activating maturation of the lymphocytes. And TNF alpha is a cytokine that can stimulate inflammatory responses, induce nerve swelling and neuropathic pain, and promote cellular apoptosis via its cytotoxic effects. So these markers could be elevated in acute low back pain. This research paper in particular did a review of a couple different papers. So you'll see here in this retrospective study from 2006, the patients studied were acute low back pain by pain and disability. They found TNF alpha and interleukin 6 to be positively correlated to pain severity. And then here, this is from 2014, lumbar disc disease undergoing surgery and controls. So they had 50 lumbar and 50 control patients. And then HSCRP was almost 30 times higher in lumbar disc disease patients versus control. That's pretty significant. Back in 2012, undefined chronic low back pain by pain and severity and the number of osteopathic lesions. So interleukin 6 and interleukin 1 beta correlated with the number of osteopathic lesions, and then interleukin 6 correlated with low back pain and severity. So again, just to show you that there was an increase. And then here in 2014, there was a decreased frequency of Th17 in chronic low back pain versus controls, but the increased frequency of Treg cells in chronic low back pain patients versus controls. So finding different things, but some good stuff just to show that there could be a positive correlation between pro-inflammatory cytokines and pain levels. So this was in 2016 by Wang et al. Severe versus mild sciatica, 58 severe, 50 mild, and then 30 healthy. So interleukin 6, 1.5 times higher in severe than in mild or control. Interleukin 8 was higher in severe than in controls. TNF alpha was 2 times higher in severe than in mild or controls. Interleukin 4, 2 times higher in mild than in severe controls. Interleukin 6, TNF alpha, interleukin 10 all correlated with the ODI, which I have to look back at the paper to remember, but I believe it's the index for pain. So, investigation of high sensitivity C-reactive protein and the erythrocyte sedimentation rate in low back pain patients. So this is a different study. I felt like this study was not as good. If you read the paper, I can send it to you via the portal, but in conclusion, in low back pain patients, they found that CRP and ESR levels were expected to increase much more than they observed due to inflammatory reactions, but neither the ESR or the hsCRP values were elevated above the normal reference values. So in cases where ESR or hsCRP values are significantly raised above normal, further investigation should be carried out to ascertain possibility of underlying systemic infection or inflammation. So just a reminder, just because it's in the literature doesn't mean everybody's finding it. But again, I felt like if you read this study, it just wasn't as good as the review of the literature that was in that last study. Just wanted to throw that in there so you had it. And just a reminder. Biomarkers for chronic neuropathic pain and their potential application in spinal cord stimulation. So these guys found a ton of pro-inflammatory cytokines. So they had interleukin 1 beta, 6, 2, 33, CCL3, CXCL1, CCR5. You don't really need to know all this, but TNF alpha. I see the big ones that I was finding in the literature was interleukin 6 and TNF alpha. They've been found to play significant roles in the amplification of chronic pain states. So after a review of various studies relating to pain biomarkers, we found that serum levels of pro-inflammatory cytokines and chemokines, such as the ones I just read, were significantly upregulated during chronic pain experiences. On the other hand, anti-inflammatory cytokines, such as IL-10 and 4, were found to show significant downregulation in chronic pain states. So, interleukins aren't all bad, right? You've got these anti-inflammatory cytokines, such as IL-10 and IL-4, that should be working, but in the chronic pain state, they're downregulated, which means that you'd probably experience pain more. And then biomarkers for depression, just because we talk about it, I think it's important. I believe that depression can definitely stem from an internal systemic inflammatory state that has not been addressed. So some recent insights, current challenges, and future prospects on it. So some biomarkers with potential translational use for depression. These, again, just a review of some of the literature. This gets pretty deep into a little bit of everything. So we have inflammatory stuff, just as some of the things you guys just saw. So interleukin 6, CRP, TNF alpha, interleukin 1 beta, you've got the 2, 4, 10, all those interleukins in there. Growth factors, so BDNF, VEGF, nerve growth factor, insulin growth factor, neurotransmitters. So all these could be assessed to see, and just looking for fluctuations in the lab findings and associating with the clinical symptoms. But then even looking at metabolic factors, so if you got dysregulation of blood sugar, that can lead to a pro-inflammatory state. So it's important to not just look at these pro-inflammatory cytokines, but say, hey, how is the blood sugar regulation? Is it chronically high? Is it chronically low? Is it swinging in between high and low? Anything like that could contribute to an inflammatory state in the system, as well as TSH levels, and doing maybe a full thyroid panel would be a benefit for the patient, because a common symptom of hypothyroidism is depression. And the literature shows that the majority of patients who are diagnosed with a high TSH, hypothyroidism, are actually autoimmune in nature. So what's not standard of care typically in medicine nowadays is running TPO antibodies, which is not great, because if a patient is diagnosed with hypothyroidism and the literature shows that they're the majority of time autoimmune patients, it would be of benefit for the patient to know that they are an autoimmune patient in nature, and just taking their medication may not actually fix the thyroid problem. Sure, they might feel better first, but then eventually, if they're continuing to do things that are going to be driving the inflammatory state or the autoimmunity, they're never going to get 100% better just by taking the medication. So just another reminder, you got to look at the whole picture. We've got to try to figure all this out for the patient, because it's the only way they'll get better. So that's the end. Thanks so much, guys, and I hope you have a great week.